Okay, Bruce, now that we've established that the current thinking on severity of psoriasis with mild, moderate, and severe in our current tools is not optimal, give us a little background and take us through the process that the International Psoriasis Council went through when they developed these new criteria to define severity.
Yes, basically the IPC wanted to solve a problem without really consensus or hard evidence in the literature to allow us to arrive at a good end. And I had been involved in the past with what's called Delphi exercises. Delphi exercises basically were invented about 60 years ago by the Rand Corporation in the 1950s. And it was meant to answer unanswerable questions where you just had to use experts. And experts can come from any walk of life, but the experts in our instance were counselors in the International Psoriasis Council. There are actually over 70 of them, and all of them take care of psoriasis patients on a daily basis. And the point of a Delphi is things are done anonymously. Voting is done, ideas are put forth, but no one knows who's doing what voting or what ideas are coming from whom. Therefore, there's no concept of groupthink or stronger personalities winning the day. Every comment and vote is equal and just appears at the end of various rounds. So the first goal was to define, well, what are adequate definitions of psoriasis severity? And we solicited ideas from the experts in our panel, in our stable, and they, on a website that was created for the effort, excuse me, sent in their ideas, and a lot were sent in, at least 38, I believe. Many were redundant, and we had to clean them up, make some commonality themes. Some were a little bit over the top and strange, so we kind of eliminated them. But basically, we came up with over 30 concepts of psoriasis severity put forth by experts. And therefore, we had a group of definitions on which to vote. The next step was online voting for each severity definition. Now, what happened here was people voted on a Likert scale, basically, for each definition, and the top vote getters for each severity definition were lined up 1 to 30, for example. And then that order was presented to the voters. And then there was a period of discussion. In other words, people could submit anonymously again their support for various definitions that were submitted. And everyone was supposed to read them, and they did, and then vote again. So this reiterative process of voting, discussion, yet all anonymous, then re-voting, allowed us to come up with a rank list of statements that were felt to be really good at the top of the list and really not so good at the bottom of the list, based on interspersed discussion. And then we had our top 7 that were brought to one final meeting at what we call our IPC think tank. And this meeting was done in person. So the process was moved virtual to in person at this IPC think tank meeting. And everyone who had a severity definition voted into the top 7. Every one of the originators, the authors of each of those severity definitions, was allowed to present their view in person. And now it's not anonymous, obviously, because you clearly have a person standing up and defending his or her definition. And that was done. And then after that was done, a final vote was taken on the top 7. And we arrived at a number 1 statement, which actually was the statement submitted by Dr. Andrew Blauvelt. I guess not coincidentally, he's on this discussion today, but he got the top vote getter. Now, we did a little wordsmithing around the final top vote getter, only to make it a little clearer. But ultimately, it stood the test, and we were very happy with the outcome.
That's great. It sounds like it was a rigorous process. Sounds like you had a lot of input from a lot of different people. I know that for sure, actually, because I was involved in that process. It was very interesting for me to participate and to see how we whittled it down. I think one of the key themes that you'll be discussing in more detail is that we wanted to get away from 3 categories of mild, moderate, severe, and think of this disease as falling into more 2 buckets, either candidates for topical or candidates for systemic therapy. So can you discuss the final assessment and some of the features about it and some of the reasons behind those features?
Yes. So the final assessment was, like you said, 2 buckets. Patients with psoriasis should be classified as either candidates for topical therapy or candidates for systemic therapy. And systemic therapy was a priori defined as including phototherapy. The latter patients, those that are candidates for systemic therapy, have to meet at least one of the following criteria: a BSA of greater than 10%, and that's easy, or disease involving special areas, or failure of topical therapy. So now we've dichotomized the definition. You're either a topical therapy patient or a systemic therapy patient, and you just got to meet one of 3 criteria to be in the systemic therapy group. And again, special areas being one of those 3 criteria is defined as you defined it just earlier in this discussion. So very simple, easy to understand. What the group found was really interesting was, in fact, we kept things fairly objective. If you think of each of those criteria, it's very objective. BSA is objective. Special areas, yes or no. Failure of topical therapy, yes or no. And as an aside, what was not included was patient-reported outcomes, like a DLQI. And it should be noted that some of the suggested severity definitions in that initial 30 group, many of them actually, incorporated a DLQI. But ultimately, it was decided, and this was, I know this through our discussions in person, that DLQI was left out of the final definition because it's not used very often worldwide. In some parts of the world it is, but for example, in the US, it's rarely used in the clinic, if ever. And so we wanted to keep the definition very practical, that anyone's doing dermatology in any practice anywhere could quickly understand it and quickly implement it.
Yeah, I think that is an important point. Obviously, quality of life is important. We know that for psoriasis patients. But I think the key point being the tools to assess that are not widely available. And if we did incorporate DLQI, it would have meant new kind of practice for patients, especially in the US. The other controversy over it, and I want to get your thoughts on this, is we left the definition open for failure of topical therapy. So there were people who wanted to better define failure and in what particular topicals that were being used, or perhaps a length of time. But can you tell us how, for example, in your practice, how would you define failure of topical therapy and how others may do so?
You know, I look at it in 2 ways, Andy. How do you fail topical therapy? First, I think if you have just so much psoriasis on your body that it's completely impractical to try to treat with topical therapy, then that is in itself failure. It's failure without really failing. But if someone has 15% of their body covered with thick plaques, it's just inhumane and actually very expensive to prescribe topical therapy. Now, that's easy. The hard one is someone who actually uses topical therapy but doesn't get better. And we see that all the time. And people have different theories as to why that occurs. One primary thinker in our field likes to always attribute it to lack of adherence. Patients don't actually use topical therapies, therefore they're failing in a false manner. They don't open up the tube to use it. But we know a lot of patients do try to use topical therapies and they come back on their follow-up appointment and they aren't better. And that's because Psoriasis often is resistant to topical therapies, no matter what strength you use. And I think most dermatologists employ at some point in the treatment algorithm high potency topical corticosteroids, in addition to perhaps a vitamin D analog or some other combination drug that has mixtures of known therapies, and they don't get anywhere. Psoriasis can initially respond, but then lose response. Psoriasis can just not ever respond. We see that all the time. Or psoriasis can be in an area of the body that's difficult to deliver topical therapy, like the scalp in a full, thick head of hair. We have topicals for scalp psoriasis. They often don't work. There's solutions, there are foams. There's an oil that we ask patients to throw into their scalp and put in overnight with a bathing cap, which is in and of itself somewhat inhumane. But these patients often don't succeed. Now, do you need to move through potency of drugs before you decide someone has failed? Maybe, but I think that's something we do and doesn't need to be explicitly taught in this definition.
Yeah, I like the vagueness of failure of topical therapy, because I do think, as you say, in different individuals, that's going to mean different things, and so by saying failure and letting the clinician define what failure is, or the clinician and the patient, is probably the best way to do it. So that's, I think, why we kept that vague.